Professor Rossi from France. How to evaluate minimal residual disease may influence clinical decision.
Thank you.
And I wonder about which disease you are talking.
Thank you. No. I just want to change and I agree with you, Robert, that minimal, it's not a good word. I appreciate that. But I use this word because it's a definition of the NIH and NCI, but I agree for this change. Thank you for Nikolai, my friend, to invite me regularly to this meeting. And thank you for George also and all the participants. The question for today is, for me, how the evaluation of measurable residual disease may influence a clinical decision in hematological malignancies. We have seen in CLL, but we can have a look on the other malignancies also. Yes, this is my disclosures. And the definition I found is from the NCI. They use minimal, as I can talk, describing a very small number of cancer cells that remain in the body. They don't precise that it's in the peripheral blood, on bone marrow, on the other sites. It can be found with highly sensitive laboratory methods. The tools are very important. And they think that it may help plan treatment, find how well treatment is working and cancer has come back, etc. We discuss about that. There are subsidiary questions. The tools are very important depending what we want to search. The levels, in which biological liquid, is it a unique or integrated biomarkers? And for me, the most important is the dynamics, because we have to distinguish the MRD evolution after therapy, and the treatment is very important to integrate in this evaluation, describing what we are measuring: necrosis, secretion, release. The question for a clinician is it possible to cure or just to control? And could we make a tailor-made treatment for this, from this knowledge? This is a usual figure with a submerged iceberg. And as it was shown, the curability is a question depending the depth of the response, but not only on the depth, but probably on the dynamics of the evaluation. If we are focusing on the dynamics, we can focus on the prognosis at the diagnosis, then monitoring the disease and detecting early relapse, and detecting also the tumor, the resistance to the different therapies. So there are multiple tools, molecular biology. I don't want to insist on that. Molecular events, circulating DNA, circulating non-coding RNA for DNA methylation and T-cell regulation. We have also the multi-parameter flow cytometry, which is made on peripheral blood and bone marrow for hematological malignancies, but also for solid cancer, and circulating tumor cells from different solid tumors have been described. We are working in our group with Martin Villalba on the immune cells contact with the tumor, and using trogocytosis also for MRD evaluation. It's just starting. We have some preliminary data in lymphoma, in different sites like ocular sites, for example. So, in the literature, the comparison between multicolor flow cytometry, quantitative PCR or next generation sequencing has been made. I want to just mention that, the sensitivity from 10⁻⁴ to 10⁻⁶, the advantages between these different techniques, the limitations which have been described earlier, requiring fresh cells for flow cytometry, and the different differences between the different laboratories and the need for some regulation, accuracy, and so on. This is a summary also between the comparison between the different hematological malignancies, AML, BLL, ALL, CLL, and multiple myeloma, with a summary of the sensibility and the threshold from 10⁻³ to 10⁻⁵ in multiple myeloma, showing that in multiple myeloma, I think it's the best way for using that, because we are in the situation of the site of the tumor in the bone marrow, and it could be, it has been demonstrated, the linkage between, the correlation, excuse me, between these evaluation and the survival. The backbone panel and the additional markers have been described in this slide, and you can have this in the literature. So I want to focus on the dynamics, which is very important and necessary to have in our mind. In CML, this is the best example. We have to calculate the ratio of the slope of the reduction curve, and we can interpret the reduction in cell number and transcript, which is the correlated to the decrease in the first months, and after the falling levels of BCR-ABL are proportional to the depletion of leukemic cells. This is important because it supports the notion of what we are measuring: necrosis, number of the cells, and the different aspects of the biology of the tumor. So, at a clinical level, it has been demonstrated, and you know that molecular response at 3 months is correlated to the cumulative incidence of a complete molecular response and also PFS and survival. And this is the most important example of what we can use monitoring of measurable disease in the situation of therapy. So, the prognosis of the molecular response at 3 months may push the clinician to change the inhibitor of tyrosine kinase. We also have the possibility to, by monitoring with NGS, to change TKI because there is a resistance, or to stop it after some different after the complete response, which is prolonged, and discuss for the future alternative situation in terms of therapy. So NGS may also detect atypical or additional molecular abnormalities as described in CML, or to detect the therapy-resistant mutation, for example. In AML, I don't want to focus on this. There are many molecular events at the diagnosis, which have been described extensively in the literature. We know that in AML, there is a risk stratification by using this genetic abnormalities evaluation. We know that in the dynamics, and I want to focus on that point, there is a clonal evolution, meaning that the dynamics of the monitoring is more important than having one point of the evaluation of the measurable residual disease. This is an example published in the literature from a patient having a MDS going to a leukemia, and this is the example of the situation of the mutation of IDH2 and FLT3. The pressure of the treatment, and as Robert said is very important in this analysis. We are, by this dynamics evaluation, we have the treatment modality and the mode of activity going to the biological factors, the death rates, the proliferation rates, the stage grades, the cancer biology, and other markers, including immune markers for the future. And the dynamics allows us to evaluate correctly the patient response and outcome, and also for research in this situation to evaluate the biological insights, which could be important for the future in terms of clinical therapy. This is another example of the interest of the dynamics. As I mentioned to you, we have to evaluate the cell death by apoptosis, necrosis, or the secretion of the different markers. And the most important is to evaluate the response with a favorable outcome when it's unmeasurable or under one level, which has been to define. And this means the clearance. If not, we have a progression or resistance or persistence of the disease. So in this situation, we have also to evaluate, because it's difficult sometimes, the difference between clonal hematopoiesis, which could be a biological noise in liquid biopsy, for example, and targeted sequencing of pair circulating DNA and white blood cells could correct the origin of the mutation and distinguish this situation of the clonal hematopoiesis. Just some example in pediatric ALL in the context of transplantation. We have on this slide the event-free survival, which is better when we combine an immune response and a situation with a minimal or negative minimal measurable residual disease. It's shown on this slide in relapse probability, in survival, as well as in EFS. But I agree with you, Robert, that we have to have these different parameters and not only focusing on the biologic parameter, but the survival is the most important. In myeloma, it has been demonstrated that MRD negative is also correlated to PFS, but also in the new programs with overall survival. And we have to choose between NGS or cytometry, multi-parameter cytometry, flow cytometry, which is a good way to analyze. And we have in Europe a community of scientists working on this. Just an example of somebody who have ALLB, Philadelphia negative. It's somebody from my family. I show you this. He is treated in a good French center, but no NGS, no evaluation at diagnosis of this ALL. And also, particularly during the COVID period, there was no evaluation, just a bone marrow aspirate for just a standard evaluation. And he relapsed very rapidly during this period without any therapy. He had ipercevad and blinatumomab, and now it's an allogeneic proposal for him. But another situation could be this, with an initial NGS and a dynamics of the evaluation of minimal measurable residual disease, we can detect earlier. And the proposal from the MD Anderson was mini ipercevad, 2 bispecific monoclonal antibodies and CAR T cells. I don't know what is the best way, but this is a proposal, And unfortunately, he had allogenic heart transplantation, which is ongoing today. So if I summarize therapeutic possibilities under MRD monitoring, we have to analyze it in a clinical research programs, but also in some disease in a standard situation, and maybe we can learn about that with Dieter after. Evaluating regularly, I don't know the frequency, but in a clinical research program, it's every 3 or 6 months, particularly detecting the early relapse and to adapt probably for the future the different targeting therapy, the immune therapy, which is very important not only in the situation of the control of the measurable residual disease, but also in other situations, and probably other possibility like anti-metabolic therapy, etc. We have just in few slides some additional opening with, for example, we are working on inflammatory and dysregulated inflammation, which is present in cancer and particularly in some cancers with hematological malignancies, but also solid tumors. And probably the modelization of the usage of some anti-inflammatory system could be used. We develop a mathematical modelization of that with the anti-IL-6, and I don't have the time to detail this mathematical model, but these are the example of the usage of the tocilizumab or ciltuximab in different situations of the inflammation, meaning the CRP at 4 and IL-6 at different levels. And we know that in this situation, the antibodies are not efficient because it's not the good dosage, it's not the good schedule, it's not the good combination. We have to probably through the mathematical model and to reassess the usage of some drugs. This has been also developed in CTLs, but it's not used actually in the clinic. This is an example in breast cancer. And we also have other possibilities. We know that immune adjuvants could be helpful. Cancer vaccines, some example from Petrovac and from a small company, we are working on cancer vaccines. We have to expand the framework of measurable residual disease in solid cancer as well as in hematological malignancies, probably by including microbiota, exosomes, or all the different types of things. The interaction between host and cancer are very important to analyze in the future. So beyond MRD, the dynamics is very important to define the precision medicine, focusing on cancer cells, tumor microenvironment, and the patient too. This is the end, take-home message. Reaching measurable residual disease is a clinical goal. In some disease, depending on the therapy, by using different techniques, by using different analysis, but in a dynamic situation. And we have an opening situation beyond the MRD with multiplexed analysis. And to predict the efficacy, we can use some models that has been developed. Thank you for your attention with the different collaboration we have in our team. Thank you.
Thank you. Great talk. Questions? I will start. So if you have in any of the diseases, a minimal residual disease situation, how to detect the residual cells? I mean, we call it minimal residual cells, not detectable, but clearly there are still cells. So what is your opinion? You mentioned in your second last slide several methods. but what is reality?
For today, the reality is multi-parameter color flow cytometry, but I think the NGS at diagnosis and in some situation could be very important to add to multi-parameter flow cytometry.
So, would you follow NGS and minimal residual disease? It's a question of cell number to apply the methods, or? So there are certainly many other questions from the audience. Professor Gale, how does what he was saying fit to your models?
Well, I mean, a couple of comments. It's not entirely correct that, let's take CML, which is our best model.
Probably.
Should we make clinical decisions based on PCR data at 3 months? I would say no. I mean, because if you start someone on imatinib, you can get a deep molecular response just later, right? So the survival of people who get a deep molecular response, quickly or slowly or however you like, their survival is the same. So I know it's a very popular idea to switch to a second or third generation TKI. But in fact, the data don't support that. I mean, our survival in CML is so good that it's almost impossible to...
So what is the decision making? I mean, there are...
Well, the decision making is, you know, after a year on imatinib, if you don't get to a deep molecular response, you better change. Now, other people like Beppe Salio, they say, well, I want...
Beppe,
I
you are... No, you are mentioned. Probably you should stop a second in the computer.
Oh, there he is, yeah.
Yeah.
So, I mean, he loves nilotinib. So, you know, if somebody doesn't get a very quick response, you know, he switches them to nilotinib right away. But, yeah.
Yes.
Please. Any event, I wouldn't have started this if I knew you were here. I wouldn't have mentioned you.
But we...
Any event, I think it's complicated, and at the end of the day, just to make it brief, at the end of the day, we have to remember that you don't have to get rid of every cancer cell to cure cancer. I mean, with cytarabine and daunorubicin, we cure 30 or 40% of people with AML. You know, no one in their right mind thinks that 7 days of cytarabine and daunorubicin is killing the leukemia stem cell.
But you must admit it was a great idea to combine the two drugs, and it works for such a long, surprisingly for such a long period. But we have to discuss your talk.
Well, it was a brilliant lecture, and I enjoyed it.
Thank you, Robert. In my personal usage, I follow you. I don't change at 3 months. I wait for 6 and 1 year, and I change at this moment. But it's in the literature, I mentioned that. I agree with you that we have to wait because we have some delayed response, molecular response. And the second part is probably with this model, we can assess for stopping TKI, which is more also a question for now than changing at 3 months.
But it's also a matter of clinical practice. I mean, you cannot leave it to the individual decision of any doctor treating, so you must have rules. Sorry, and you know, I understand what you're saying, or Bob, waiting for 1 year, but does it help a clinician in the city number X to treat his patient?
Yeah, I agree with you.
Other questions? Yeah, please.
No, I think we have to wait and not to change at 3 months. It's too early, but it's in the literature. I mention it. But you have probably another response.
My comment is that, of course, we have to wait in one sense, but it's possible also to perform an analysis in a shorter time, I would say, few weeks, 1 month, and so on, and to see which is growing. And this is very important to establish. This is what we are doing generally in CML, no? So we are not relying on a single analysis, particular molecular, but we are indeed repeat the analysis to take a decision. But it's true that the persistence in specific diseases of some is associated with the worst prognosis, so it's better maybe to wait a longer time.
Yeah, the dynamics is very important.